and Recovery webinar. I am Berlina-Wallace Berube, a Senior Public Health Advisor in SAMHSA Center for Substance Abuse Treatment. Before we begin, I would like to note closed captions are available for accessibility. If you just take a look at the bottom of your Zoom window, you can go ahead and click the transcript button to see the captions. Please note that today's session is being recorded. A recording will be posted on the SAMHSA website as soon as possible. The chat and Q&A functions are disabled for this webinar, as we will not be taking questions during today's session. Continuing education units are not being offered for this webinar. We kindly ask participants to refrain from using AI note-taking tools or other recording devices, as they are not approved to record this session. If you experience any technical issues, please contact Amy Rabin or Josh Shapiro. Their email addresses are shared in the chat. And with that, we will begin to explore pathways to treatment and recovery. First, let's take a look at substance use disorder in general. Substance use disorder is a chronic health condition that affects how the brain works, making it difficult for some people to stop using substances even when there are adverse consequences. These changes in the brain can persist, which is why people may return to alcohol and other drug use even after long periods of sobriety. A return to use is common, but doesn't mean treatment failed. Like treatment for other chronic illnesses, so think diabetes, hypertension, those types of chronic conditions, addiction treatment must be ongoing and adapted to fit the person's need. Addiction risk varies based on 3 key factors. Biology. Genetics account for about half of a person's risk. Other factors also play a role. We'll also look at environment, the second factor. Family, friends, economic conditions, and life experiences such as peer pressure, abuse, or early exposure to drugs can influence addiction risks and development. Drug use during key stages of life, especially adolescence, increases the risk. Teens and young adults' brains are still developing in areas that control decision-making and self-control, making them more likely to engage in risky behaviors like drug use. Substance use disorder is often misunderstood, but it is not a moral failing, a lack of willpower, or a character flaw. It is also not a disease of morality. These misconceptions create stigma and shame that can prevent people from seeking help. Understanding substance use disorder as a health condition helps promote compassion, support, and recovery. There is no single path to treatment or recovery. During treatment month, we have been highlighting that all this month. Recovery is highly individualized, and people may move between different pathways as their needs and circumstances change. Effective systems support clinical, non-clinical, and self-directed pathways, all of which can lead to long-term recovery and improved quality of life. Let's take a closer look at the various pathways to treatment and recovery. First, we'll start with clinical pathways, which include care provided by licensed professionals within formal systems such as healthcare or justice settings. These pathways are evidence-based and regulated. They focus on addressing medical, behavioral health, and substance use-related needs through services like outpatient or residential treatment, medications for substance use disorder, and behavioral and mental health therapies. Non-clinical pathways occur outside traditional healthcare systems and emphasize connection, peer support, and shared lived experience. Participation is typically voluntary and ongoing, with examples including mutual help groups, peer recovery support services, recovery community organizations, and faith-based supports. Recovery housing, which we'll take a closer look at later on, is a key recovery support that bridges treatment and long-term recovery by providing safe, stable, substance-free living environments. Recovery housing supports structure, accountability, and connection to treatment, employment, and community-based services, and can be used alongside clinical and non-clinical pathways. Self-management pathways recognize that many people recover without formal treatment or structured programs. These pathways are driven by personal motivation and everyday life changes, such as shifts in social networks, employment, or education, healthier routines, and informal support from family members and friends. Many individuals use multiple pathways because recovery is not a one-size-fits-all process. Across all pathways, recovery is possible, and each can contribute to long-term health, stability, and improved quality of life. Behavioral therapy, also referred to as counseling, is an important pathway to substance use disorder treatment because it helps people better understand their substance use and build practical skills to support recovery. It focuses on the behavioral, emotional, and social factors that often influence substance use, such as stress, trauma, mental health conditions, and relationships. Counseling can be effective on its own for some individuals and can also be combined with medications and other supports for others. There is no single approach that works for everyone, and people may use different types of counseling at different points in their recovery. Approaches such as cognitive behavioral therapy and dialectical behavioral therapy help individuals identify patterns, strengthen motivation, and develop coping strategies. Counseling may take place in individual, group, family, or couple settings. When counseling is person-centered, flexible, and aligned with individual goals, it can support reduced substance use, improve mental health, stronger relationships, and long-term recovery. Research shows that combining medications with counseling or therapy is an effective way to treat substance use disorders. For some people, medication alone can be sufficient to support stability and sustain recovery, even without formal counseling or therapy. The FDA has approved several medications to treat alcohol use disorder and opioid use disorder. These medications work by reducing withdrawal symptoms and cravings and by helping restore balance in the brain and body. Medications used to treat substance use disorders are evidence-based and they are carefully regulated, and they do not replace one addiction for another. Let me just highlight that again. Medications to treat substance use disorder do not replace one addiction with another. Instead, they support recovery and help people function, stabilize, and engage in treatment and daily life. Also, certain medications are used to prevent or to reduce the risk of opioid overdose and to save lives. And there on the screen, you see the different medications in their various categories. Access to treatment and the ability to stay engaged in care are often shaped by real-life social and structural factors. Just like everything else that we do in life, we're more motivated when we are supported and when we have what we need. Stable housing is a critical support that increases treatment engagement and retention, while housing instability can make recovery much more difficult. Transportation barriers are a common reason people miss appointments or discontinue care. Strategies such as transportation vouchers, telehealth, and mobile treatment services can significantly reduce these barriers and improve continuity of care. Employment and a stable income support recovery by promoting routine, purpose, and financial stability, and by reducing stressors that increase the risk of returning to substance use. Family and caregiving responsibilities can either hinder or strengthen recovery, depending on the level of support available. When accommodations are not in place, these responsibilities may limit access to treatment, but when addressed thoughtfully, they can increase motivation and engagement. Family-centered approaches include flexible scheduling, childcare coordination, and services that intentionally include and support families. Peer recovery support specialists play a critical role in connecting people to care and services by building trust and reducing stigma. Because peers have lived experience with substance use and recovery, they are often able to connect with individuals in ways that feel more relatable, non-judgmental, and supportive. Peers help individuals navigate complex systems of care, including healthcare, treatment programs, social services, and community supports. They can assist with understanding options, overcoming barriers, and advocating for individual needs and preferences. Peer support can occur during, and after treatment, helping people engage in care, remain connected, and transition successfully between services. In many cases, peers serve as a first point of contact, especially for individuals who may be hesitant to seek formal treatment. By strengthening engagement and continuity across different pathways to recovery, peer services help really bridge gaps in care and support long-term recovery and stability. Faith-based and community organizations often serve as trusted and accessible entry points to support individuals and families affected by substance use disorder. Because these organizations are rooted in local communities, they can respond quickly and in community-specific and spiritually relevant ways. These settings help reduce stigma and isolation by offering welcoming, non-judgmental spaces where people feel seen and supported. Faith and community organizations may provide emotional and spiritual support, practical assistance, and connections to trusted peers. Many also play an important role in making referrals to treatment, counseling, and recovery support services, helping individuals navigate next steps and access formal care when needed. Community connections can encourage help seeking, strengthen motivation, and sustain recovery beyond formal treatment by fostering belonging, purpose, and ongoing support. SAMHSA supports individuals, families, and communities by strengthening access to treatment and recovery resources across the full continuum of care. This includes promoting evidence-based, person-centered, and recovery-oriented approaches that meet people where they are and respond to their unique needs. Through its programs and initiatives, SAMHSA works to reduce barriers to care, expand access to effective treatment, and support long-term recovery. SAMHSA recognizes that recovery does not end when treatment ends, and that people benefit from ongoing supports that help them build sustainability, connection, and purpose. The next few slides that we'll take a look at will provide examples of how SAMHSA supports treatment and recovery in practice. SAMHSA's Center for Substance Abuse Treatment, or CSAT, works to close the gap between available treatment capacity and demand. CSAT also supports the adaptation and adoption of evidence-based and best practices by community-based treatment programs and improves and strengthens substance use disorder organizations and systems. CSAT's work supports states and the community-based groups to improve and expand existing substance use disorder treatment services under the Substance Use Prevention, Treatment, and Recovery Services Block Grant Program and the State Opioid Response Grant Program, And we'll take a closer look at both of these programs in a minute. CSAT also supports SAMHSA's free treatment referral service that connects people with substance use disorder services in their communities. So now for the Substance Use Prevention, Treatment, and Recovery Services Block Grant, or SUPTERS BG, which is a formula grant program that distributes approximately $2 billion each year to states, territories, freely associated states, the District of Columbia, and the Red Lake Band of Chippewa Indians. These funds support the planning, delivery, and evaluation of substance use disorder prevention, treatment, and recovery support services. The overall goal of SUPTERS BG is to strengthen and expand substance use services while providing states with the flexibility to meet local needs. Funding flows through states through a wide range of partners, including local governments, administrative service organizations, and prevention, treatment, and recovery providers. SUPTERS BG is critically important because it offers a stable federal funding source that allows states and communities to respond to emerging public health and public safety challenges related to substance use in ways that are locally informed and timely. The State Opioid Response Program addresses the public health crisis related to opioid misuse and opioid use disorder and overdose nationwide. SOAR is a 3-year grant program awarded to states and territories to support locally driven evidence-based responses. SOAR funding is used to expand access to FDA-approved medications for opioid use disorder and to support the full continuum of prevention, treatment, and recovery services. SOAR also supports care for stimulant misuse and use disorders, including cocaine and methamphetamines, with the goal of reducing overdose deaths and improving outcomes across America. Now that we've taken a look at SOAR, let's take a look at TOR. SAMHSA's Tribal Opioid Response Grant Program supports tribes in addressing opioid and substance use challenges through comprehensive, culturally grounded approaches across prevention, treatment, recovery, and traditional practices. TOR funded expands access to treatment at all levels of care, helping fill gaps and ensure timely, ongoing services. Prevention efforts emphasize community outreach and education that engage youth, elders, and other community members, including naloxone trainings, health fairs, gatherings of Native Americans and Alaskan Natives, and social media awareness campaigns. TOR also supports peer recovery services, recovery groups, recovery housing, aftercare, and wraparound services that help individuals sustain recovery. Traditional practices are a core component of TOR activities, with many tribes incorporating approaches such as talking circles, sweat lodges, dance and drum ceremonies, and traditional healers to promote healing, connection, and community wellness. These examples show how TOR funding supports timely, coordinated, and responsive care. One organization uses a multidisciplinary team, including pharmacists, behavioral health providers, and peer recovery specialists to quickly connect individuals to treatment. For example, when someone sought help through in-house urgent care, the provider prescribed medication and made an immediate referral to a treatment clinic, allowing same-day or next-day access to care. Over time, the person moved into stable recovery, including securing housing leadership roles, and even started their own business. Another organization focused on integrating tribal practices into services by training staff and empowering peers to lead groups grounded in Indigenous principles. Outreach efforts include pop-up events in the community spaces, distribution of naloxone kits and test strips, and partnerships with local businesses to create multiple access points for life-saving resources. SAMHSA recognizes recovery housing as a key recovery support that provides safe, stable, and substance-free living environments. Recovery housing can support individuals whose current living situations are unsafe or do not support long-term recovery. This includes those who are currently or recently experiencing homelessness. It can be especially helpful for people re-engaging in recovery after a return to substance use or for individuals transitioning from incarceration when a substance use disorder is present. Recovery housing is often used after completing residential treatment or while participating in outpatient care to provide structure, accountability, and peer support. It may also be a valuable option during major life changes or periods of increased stress when additional support is needed to protect recovery. Recovery housing offers a continuum of options designed to meet different needs and stages of recovery. Levels of structure, rules, and services can vary widely and are commonly grouped in 4 general residence types, and we'll take a look at those next. Movement between residence types is expected as individual needs change over time. Recovery housing also varies in size, ranging from small homes to large facilities, with most residences housing between 8 and 11 people. Not all recovery housing models are available in every community, and this makes local coordination and partnerships important. The National Alliance for Recovery Residences and the American Society of Addiction Medicine describe recovery housing along 4 general residence types, which differ by level of structure, staffing, and services. Level 1 or Type P residences are peer-run and democratically operated, relying primarily on neutral peer support. Level 2 or Type M residences add staff monitoring to support structure and accountability. Level 3 or Type S residences include staff monitoring along with more structured programming focused on life skills development. And Level 4 or Type C residences offer the highest level of support, combining peer recovery support, life skills programming, and clinical services. Individuals may move between residence types over time as their recovery needs change. Recovery residences often reflect the values and the traditions of the communities they serve, and this includes local recovery cultures. Residents may support one or multiple recovery pathways. Common pathways include 12-step-based models, faith-based approaches, tribal traditions, and alternatives such as smart recovery. All recovery residences are grounded in abstinence from alcohol and illicit drugs. It is very important for us to note that the use of FDA-approved medications for substance use disorder is consistent with abstinence. Remember, you are not alone. Treatment works and recovery is possible. You can access resources by calling SAMHSA's National Helpline at 800-662-HELP, or that is 800-662-4357, by calling or texting 988, or by chatting at 988lifeline.org. Substance use disorder care offers a range of treatments to meet you where you are. Find treatment that works for you by going to findtreatment.gov or by scanning the QR code on the screen. If you know someone who is experiencing a substance use disorder or is experiencing problematic substance use, please also share findtreatment.org with them, as well as the other resources such as 988. The truth is, any step toward positive change is an important step. There are multiple pathways to treatment and recovery, and so we encourage you to find your path today. Now we will transition to the second portion of the webinar, where we connect this year's theme for Substance Use Disorder Month, which highlights multiple pathways to treatment and recovery that we just spoke about, with the value of lived experiences from my SAMHSA colleagues who are in recovery and who have provided treatment respectively, David Awadalla of the Office of Recovery and Angela Caldwell of the Center for Substance Abuse Treatment. I will turn it over to Angela to begin the discussion.
Thank you so much, Berlina. That was great. Okay, David, let's start with you. Do you mind telling us a little bit about your personal and professional journey?
Yeah, sh sure, Angela. And first thing, I just want to express my appreciation for all of our local and state partners who joined us today. I appreciate, and my SAMHSA colleagues appreciate all the hard work that you're doing to treat people and support people who have substance use disorders across the nation, and we recognize that. So thank you for being here with us. So my name is David Awadalla, and I'm a public health advisor with SAMHSA's Office of Recovery. In that role, I serve as the GPO for our CARS Recovery TA Center. CARS stands for the Center for Addiction Recovery Support. And so that center offers training and technical assistance related to recovery and recovery support services. And that is a free to use resource for all our public partners as well. So I just wanted to let you all know that. I also serve as the SME related to peer support and recovery support services. And much like many of my colleagues across SAMHSA, I wear a few different hats professionally. In addition to working with SAMHSA's Office of Recovery, I also identify as a person with lived experience with addiction. I'm also formerly incarcerated, and I identify as being in long-term recovery. And just to provide kind of a brief snapshot, if that's possible, of kind of the journey that led me to where I am professionally. I always knew that something was different about me when I was younger and growing up. I always felt like I couldn't quite fit in. Always was searching for something that felt like it was missing socially. And I always felt very insecure growing up. And the way I filled that gap, and I identified what I could do to change that missing piece of my life, and I was using substances. And actually I remember the first time that I was prescribed an opioid. And I'm sure many of you have heard this story before, but I actually was prescribed it for a legitimate reason. It was for my wisdom teeth. And I remember taking a Vicodin for the first time. And I remember sitting down and thinking, this is what I want to feel like forever. And that was the moment where I think my life changed. And it took a few more years to get to a point where I would be classified as having a moderate or severe substance use disorder or opioid use disorder. But that led me down a dark path that involved, eventually progressing to IV heroin use. And thankfully, I was able to access in 2014 and 2015 treatment. And that sparked my current recovery journey. And I think we're going to talk a little bit more about what that recovery journey entailed and the different recovery support services, including some of the clinical treatment modalities that played such a big role. But before we do that, I'm going to hand it over back over to Angela. So Angela, can you tell us a little bit about your professional experience and kind of what led you or sparked your passion for treating people with substance use disorder?
Absolutely. Thank you, David. So, yeah, just to give you a little bit of background, I had a family member that was in long-term recovery all my life. So I was exposed to Alcoholics Anonymous as a little girl. And then I had another family member that struggled with substance use disorder. And we had to go to an intensive family substance use disorder treatment weekend. And it really changed the trajectory of my family's life. So at age 14, I knew that I wanted to work in this field. So when I pursued my undergraduate degree, I started in inpatient treatment, and then I moved over to opioid treatment program, and I was there for 22 years, and I became a very staunch advocate for medications for opioid use disorder. And then I came to SAMHSA in 2020, and it was a really perfect transition because I was assigned as a GPO to the MAT-PDOA portfolio, which stands for Medicated Assisted Treatment, Prescription Drug Opioid Abuse. So I came from working at an OTP to overseeing grants that worked in the OTP world, and I was very new to the government, so what I was learning on the grant side, I could really provide perspective to the grantees on the professional side because I literally had just come from that role. I've been at SAMHSA now for 5 years. I oversee a lot of portfolios, and I'm just very, very passionate about this subject. So I'm glad to be here to be having this discussion with you. And then I guess we could kind of move over into the relationship between treatment and recovery. And so I'll start with defining treatment. Here at SAMHSA, we believe that treatment is defined as professional services, as Berlina mentioned earlier in her presentation, that can include medication, counseling, behavioral therapies, and supportive interventions. And the goal for treatment is to help individuals either stop or reduce their substance use, address related health issues, and improve their functioning. And so I'll pass it to you, David, to talk about recovery a little bit.
Yeah, so thank you, Angela. And so SAMHSA defines recovery as a process of change through which individuals improve their health and wellness, live self-directed lives, and strive to reach their full potential. Now, that recovery definition is referring to the process of recovery for an individual. But I also want to mention that a person's pathway or recovery pathway can include clinical treatment modalities. And earlier Berlina was referring to the different pathways of recovery. And oftentimes, in fact, based on my personal experience, a lot of people will have multiple modalities or pathways within their personal pathway of recovery. And so oftentimes I think we have a tendency to oversimplify it as, oh, their pathway is just recovery housing or just clinical treatment or just peer support. But I can speak personally that mine was a combination of recovery support services, which included peer support, community, mutual aid groups, which include 12 steps. At one point, it was medications for opioid use disorder. Recovery housing played an integral part at one point in my recovery. And that also speaks to how a person's recovery changes over time as well, because it's a process. And there's actually a saying that we say in the kind of the recovery community and even in the kind of the professional community that works across the recovery ecosystem, that there are as many pathways as there are people. Because every single person's pathway is a little bit different from the others. And while there might be some similarities, there's almost always some sort of difference. I can say that there's not one specific treatment modality that was more important than the other for me either. And so, Angela, can you actually share a little bit about your experience with patients who've utilized the different clinical treatment modalities? Maybe talk a little bit about MOUD and 12-step pathways simultaneously, and how those were or impacted by the treatment that you provided.
Yeah, sure, absolutely. So, as I mentioned earlier, I worked at an opioid treatment program. So, historically, in the 12-step recovery rooms, like you've heard of Alcoholics Anonymous, Narcotics Anonymous, I think the intention for a lot of the members with the goal was the implied goal was abstinence, right? So we would have patients who were taking methadone or buprenorphine, and they had an inner conflict because they wanted to participate in the 12-step recovery process, but they felt, am I being dishonest because, I'm taking this medication, but a lot of the people in the rooms are, you know, clean. That was the phrasing they use. So as clinicians, we tried to walk them through this. We said, in any other arena, we're not really expected to disclose our personal medical history. Like I don't walk into an office and say, "Oh, I take lisinopril for high blood pressure," or "I'm on insulin for diabetes." We're like, you can still work these 12 steps of recovery with your sponsor, and you don't really have to disclose that. Some people would decide that they would choose to disclose it to their sponsor. They said, I will feel comfortable having my sponsor know my story. We also started to institute something called Methadone Anonymous. So when we instituted that at the opioid treatment program, they said they felt a little bit safer. But just to be clear, Anonymous says that the only desire for membership is the desire to stop using. So we would also convey that to them that there are multiple different pathways, and just because you take a medication, not unlike if you had to take Lexapro for depression. This is a treatment plan between you and your provider, and you can still be involved in these 12-step programs. So that's kind of how they navigated that. And I found that when they utilized MOUD and 12-step recovery pathways together, they had really positive outcomes. And then, David, let's shift a little bit about peer work. Would you mind sharing about, peer work through the lens of the Office of Recovery?
Yeah, thanks, Angela. I'll say that peer support is integral to the work we do in the Office of Recovery. Everything is kind of based around the importance of lived experience, and the shared lived experience between two people. And it is reflected back in our work with developing the national model standards for peer support certification. When we developed the CARS NOFO, it was all based around peer support and recovery support services. And, I'll also say that a lot of my colleagues in the OR also identify either as family members of people with addiction or substance use disorder, people in recovery like myself, and people with co-occurring substance use and mental health conditions. And so all of us also who are in recovery, or have experience with those services have benefited from peer support at one point. I think we've realized over time, and it's become an evidence-based service, is that peer support is life-saving. And we've also realized that peer support isn't provided in one specific setting. It's provided in emergency rooms after an overdose. It's provided in carceral settings with forensic peers, or peers who have lived experience in the justice system, and the court system. It's provided in RCOs, or recovery community organizations, and it's provided in clinical treatment programs. And so, some of the most robust and effective treatment programs that I've had the pleasure of being part of and seeing have actually combined the forces of licensed mental health professionals and physicians, and people who provide those clinical tools and effective evidence-based clinical care, and then also peers who provide that shared lived experience. And kind of, Angela, as you alluded to, the effectiveness of when you combine MOUD and then you combine that with like a mutual aid group, or 12-step support group, it's that much more effective. And I think the data tells us that we're seeing it every day with the people that we treat. And so my hope is to see that momentum continue. And so Andrea, can you discuss? I think you said a little bit about your experience working as a clinician with peers. Did you, like in your treatment program, did you have one or two peers embedded there? Can you tell us a little bit about the structure and how that worked?
Sure. Absolutely. First of all, I love the peers. I was fortunate we hired a peer in 2019, right before I came to SAMHSA, and I can't overstate how much peers enhance our clients' experiences. And just to give you the audience a little bit of a background, at my opioid treatment program, a lot of our services were very referral based. So we had a lot of relationships with different providers. And in my 21 years at the OTP, I found that my clients' biggest frustrations were these barriers to services. And so, for example, one challenging issue for some of our clients is they didn't have a valid identification card, right? And as you all know, MBA is can test the best of us, right? And so sometimes like our clients would get frustrated, like they go to NBA, they'd have to fill out all these applications, go in different lines, and they would get frustrated and sometimes they would give up. And often as a clinician, I used to just think, I wish I could just drive them. I would drive them, I would do the application for them. I want to remove this barrier. As a clinician, that wasn't my scope of practice, but it was the peers. Or let's say a client had an emergency at 11 o'clock at night. They couldn't call us, but they could call a peer. And I will share when I had a Matt Padoa grantee, one of their best success stories was they had a client who had severe alcohol use disorder. They were in a hotel, they were heavily drinking, and they were reporting suicide ideations. And this program had just developed an app for the peers. So they were able to get a peer worker to call this person, keep them on the line, keep them safe, call EMS to, pick up this client from the hotel. The peer then met them in the ER while they were undergoing like the crisis assessment. And we're able to walk with this person until they got safety. So that's what peers can do. They can do what clinicians can't. And um, I can't say enough about them. When I started in SAMHSA at 2020, it was at the height of COVID. And I told my director at the time, Derek Cunningham, I said, on every single call, all of my grantees are telling me the peers are keeping us going. They are the real MVPs. They're wearing their mask and they're going out and meeting them at the coffee shop. They're going to their house. We would not be able to get through this without our peers. So I simply can't overstate the importance of how peers, along with clinical treatment, really benefit our clients.
That trust. It's that trust, that shared lived experience. Love it.
Okay, David, I'm going to shift it to you, like exploring multiple pathways. So, thinking about the first time you entered treatment, what did recovery mean to you, and how has that definition changed over time, if it's changed for you? And what evolution have you seen across the field with how we define recovery?
Yeah, so I guess I'll speak personally how kind of like my recovery has shifted over time. I remember back in 2015 when I finished treatment, and I kind of realized that something was missing, and yeah, I had actually while I was in the outpatient portion of my treatment, which was pretty long, because I mean I had had multiple recurrences or relapses over the previous 5 years. So I knew I needed that support. But I realized that, there was something missing. And I realized what that was my purpose, finding purpose. And so I applied to grad school and I ended up doing something that sometimes is not recommended. And I ended up actually moving away from my community to another state for grad school. But I realized that was something I needed. I needed to find my purpose. And, soon after that, and that was when the kind of the fentanyl crisis was really, really kicking off in 2015, 2016. And I started seeing my that my friends and my loved ones overdose, fatal overdoses, and I was just losing people left and right. I was also starting to struggle with my own mental health and my own recovery, and I made a personal decision with my medical provider to restart MOUD for a short period of time until I was a little bit more stable, which was kind of like frowned upon, and especially in the 12-step community, because it was at that point in time, it was so heavily communicated that, if you're on MOUD, you're not abstinent, which we now know is not true. And I think I'm a perfect testament to that. I still consider myself at that point in time abstinent and in recovery. And I don't know if I would be alive today if I didn't have the ability to adapt and shift and change my recovery over time. But battling that stigma and that almost shame, I think, and the hesitancy, I wish that barrier hadn't been there. I think that just speaks to how recovery as a process and the different tools that we offer and the different outlooks that we provide to the people we serve, how that's kind of shifted over time. And because we know now that a substance use and substance use disorder is not the same that it was 15 or 20 years ago. While there's many people in recovery from alcohol use disorder or from stimulant use disorder and all sorts of different substance use disorders, we know that the potency of the different drugs and the drug supply has changed, overdose rates have changed, and therefore we need to adapt the services and supports that we're providing and adapt how we're looking at recovery through a professional and lived experience lens. I think that's a good way to look at it. So, Angela, in practice, what barriers do clinicians face when trying to offer tailored treatment modalities and support multiple pathways? Are there any specific barriers that you faced for the clients that you served, and how were you able to navigate those while still honoring the individual?
Yeah, so it's exactly what you were just talking about, David. Again, the majority of my career was in this one opioid treatment program. So, other providers that we worked with that were treating our clients simultaneously, like mental health providers, probation and parole, inpatient detox centers, they were often reluctant to work with our clients because they were taking MOUD, and the gold standard back then, like you said, was the medical model, abstinence based only. So consequently, this had a negative impact on our clients, and I can tell you, I can't tell you how often a client would come onto our program for an assessment, and the first thing they'd say is, "How quick can I get off of this?" Because they faced the societal, and at the time, the treatment world stigma that was projected onto them. So, and even though we know, Berlina and David, you both spoke to this. MOUD has significantly decreases death, it increases retention and treatment. There's so many benefits, but at that time, there was still a little bit of reluctance for that. So our focus was really on educating our clients and both our providers on the efficacy of MOUD while also supporting their client-centered treatment choices. And we always use this analogy, but you know, we would never tell someone who has diagnosed schizoaffective disorder, not to take, their medicine, right? This was like the last chronic illness that there's still judgment about what someone takes to help them with their disease. And so we just constantly tried to honor their choices. Now, and different clients had different goals. There were clients who said, "I want to be on this for 6 months and then I want to taper." And we honored that choice. There were clients who tried to taper and they found that when they did taper, they would have a reoccurrence. So we kept maintaining them. And then there were some clients who decided, this is going to be a medication that I'm going to take for life. And, our job as providers is to support them and give them all the options that they have. Um, So, David, I'm going to shift it back to you. So, can you describe some tools that you and others believe are vital components of recovery? Like, how can those impact like their engagement in care?
Yeah, I think, as I mentioned before, the oversimplification of just one tool. I'm a true believer that most people's recovery journey incorporates different modalities, services, supports, both clinical and non-clinical. And like I said, recovery housing. Also, when I was in grad school, collegiate recovery, which was a completely peer-based service with other students in recovery, where we got to form a community because um, in college, like that's a hard thing to have, especially with other students who are your age and at similar points in their life with finding their own purpose. And I think we know that the more changes people make around the different pillars of recovery, and I didn't mention the pillars, so health, home, community, and purpose are the four pillars that prop up or are the foundation of the working definition of recovery that I mentioned earlier. And so, having a safe and stable place to live that supports the recovery, we know that's vital. Finding purpose, we know that's vital. Having a community of people who are also in or seeking recovery, we know that's important. And so, we've seen that when those services increase, that a person's recovery capital increases as well. And when a person has a higher or bigger recovery capital, they're more likely to sustain their recovery. I can both say that, personally with my own lived experience, but also professionally with the people I've worked with, that seems to be the case. So now I know, Angela, that a lot of barriers exist to both MOUD, substance use disorder in general, clinical treatment, finding support. A lot of barriers, both personally and some of that self stigma, also outside stigma, which you've kind of like talked about a little bit. But what is something that you've done to directly combat that stigma in treatment settings, specifically when staff or systems, either consciously or unconsciously, favor one specific treatment modality over another, or one specific support or service as part of a pathway over another?
Yeah, I had a few different approaches to this. One thing I try to do is I really try to honor where people are with their opinions, right? Because they're based usually on personal or professional experience. And I'll be honest with you, when I applied to that OTP back in, I'm not gonna say what year, it was in the newspaper and it just said outpatient treatment counselor position. I had no idea at the time it was a methadone clinic. So when I get there, they say, "So what are your thoughts about methadone?" And all I had ever heard was, people are still using, the parking lot, they're selling drugs. I had heard all these negative things and they were swirling in my mind. And I just said, honestly, I don't know enough about methadone to form an opinion. And they said, well, that's great. We'd like to take a chance with you. And I said, okay. And I always say I'm so thankful because again, I became the biggest advocate for MOUD. I learned so much. I learned that there was more than one pathway. And I was a little girl who knew the Serenity Prayer. Like I grew up in the 12 steps. All I knew was abstinence. All I knew was medical model. So I know what it's like to have these biases. So I think it's important when you talk to people, you honor where they are. And then always education, education. I'll give you an example. When I started the local inpatient treatment center that I had just left, ironically, they would not allow our patients to go into their facility if they needed to taper from another substance. Because as most of you know, it's not uncommon for people to be dependent on more than one substance. So even though we were treating their opioid use disorder, some people had struggles with alcohol use disorder or, stimulant use disorder. And at the time, this facility did not allow our clients to go there. So we would meet with them when we'd have meetings. And so how we started out is we said, hey, we'll deliver the methadone. All we need you to do is, when it's med time, when the nurses give them their other medications, you can provide their methadone. And then after a while, they started to trust us. And then eventually they did allow our clients to go into their facility. Same thing with the local detention center. We used to deliver methadone to their pregnant, I like to say residents, I don't like to say inmates. And then now in that county, they provide opioid MOUD. So I think it's just really important to build these relationships with other providers and talk about the evidence base and the science. And that's how they started to trust us because I was very fortunate. I was at a very credible program that was very client-centered, and we just continued to have conversations, and we allowed space for people to feel the way that they feel. And I felt that way at one point. And then, so, those pervasive attitudes can change, but we have to be willing to provide the education and have the conversation.
Perfect. Thanks, Angela. And I had a question about the role of peer voices and lived experience that and what how they play that really vital component or are a vital component in different clinical treatment models. But I think you already kind of answered that. So maybe we can skip ahead to the next question.
Okay, so David, what would you want providers to understand about relapse or return to use?
That's a hard question and a good question. I think, the first thing I'll say is relapse or return or occurrence in use. Um, it can be part of someone's recovery. It's not always part of recovery. And everyone's story is different. That's the first thing I'll say. For me, it was a part of my story for a long time. I don't even remember how many times I had a return to use while engaged in some sort of clinical care or attempting treatment and recovery supports. I think the biggest thing that I would want a clinician to know is that each person's situation is different. And for some people, it may look like a single return to use, while others it may look like an prolonged relapse. I'd also say that there's hope for everyone, no matter how many times you've seen that person have recurrences in their use. I would also say that if someone has or is experiencing a relapse or return to use, that treating them with compassion and kindness and meeting them where they're at, as you mentioned, is absolutely vital. And then, as I alluded to earlier, with kind of how the substance use disorder crisis has changed, especially nowadays, and clinicians can use their own professional judgment based on what that person might be using, and what their substance of choice is. But overdose and death is always a possibility. And so, especially for people who are in recovery from an opioid use disorder. And so being familiar with strategies that reduce the chances of overdose and other adverse outcomes, and overdose prevention, making sure that you have a good grasp on that, or clinicians have a good grasp on that, it is absolutely, absolutely vital. So, and then shifting back to you, Angela, how can systems more fully shift from regarding return to use as a moral failure to seeing it as an opportunity to mine the recurrence for information for more effectively delivering treatment to that person?
Well, it's like, like with any chronic condition, it's not reasonable to expect perfect adherence. And you were asking me earlier, how do I influence other people to accept things. So here's one thing that we could all, I think, identify with. You are never more vulnerable than when your health is in a good place. And we've all been in that plastic, that paper gown sitting on like a doctor's table. And imagine, again, I'm going to use a diabetes example. Let's say your doctor comes in. How would you feel if your provider came in and said, you know what, David, your A1C is off. I can tell you've been eating carbs. I can tell you haven't gone to the gym and you have failed. Imagine how you would feel. Like that is not our job. Like as providers, we are supposed to provide non-judgmental, unbiased support throughout the duration of your care. Now imagine if I said to you instead, David, your numbers were a little off. Why don't you tell me what's going on? And then you might say, you know what, I haven't really been adhering. I've been kind of poor with my diet. I haven't taken my medicine. And then and as your provider, I should say, okay, I know this is sometimes it's challenging to manage this disease, but I want to help you. So I'm going to set you up with our nutritionist. Let's look at your insurance. It looks like SAMHSA said you can go to the gym for free. Why don't you start by exercising 3 times a week? Like the Hippocratic Oath says we do no harm. I mean, I'm not a doctor, but I feel like ethically as a counselor or any kind of provider, it is our job to help people restore to health, however that looks. And sometimes it's going to be because they return to use. Sometimes it could be other mitigating factors. It's not always someone's fault that there's a recurrence. So I think it is our job to walk beside the person and say, how can I help you? Um, I think that's a good place to end. But David, I do just want you to answer this quickly because I think this is so important because your journey has been amazing. I mean, I can imagine, someone watching you and they might be in the throes of their substance use and they see that you're at like the Office of Recovery. So if you could speak directly to someone just beginning their journey, like what would you say to them about finding their path?
Yeah, thanks, Angela. I love that question. Um, the first thing I would say is I'm not that different than you, at all. And then I would listen. I think gaining an understanding of how they feel and where they're at is the kind of the first step in any conversation with someone else who's seeking personal or professional advice about how their recovery can play into their own career eventually. And then I'd also want them to know that I can relate to how they feel and where they are, even though I might be at a different phase in life or phase in my recovery. The chances are I've experienced something similar to what they're experiencing. Then I think finally I'd want them to know how important the pillars of recovery are. Maintaining their physical and emotional health and well-being, having a safe and stable place to live and nurture their recovery, forming and growing a healthy recovery community, and then finding their own purpose. That is really the spark I think that I've seen change a lot of people's lives. So, with that, Angela, I'll hand it back over to you to close us out.
Thank you, David, so much for this conversation. Thank you for being so transparent and sharing your story so open and honestly. This is a groundbreaking conversation, as you mentioned, in the 4 pillars of recovery: health, home, purpose, and community. Which so clearly supported your quality of life and your, long-term recovery. Your experience and those of my clients, because they'll always be my clients, are powerful reminders of why it is essential that we ensure people have access to like all the different recovery pathways that align with individual needs, values, and circumstances. And remember, recovery isn't a one size fit all, and it can change over time, but all pathways are valid. Every step towards positive change matters. You don't have to do it perfectly. And again, David, thank you for help, bring that message to life today. I'm really grateful for this conversation.
Thanks for having me, Angela. And thanks again to all our attendees. We appreciate all the work you guys do.